Thank you, Petri. Good afternoon. I'm delighted to be here today speaking about advanced analytics and how we can see value and the power of the data into healthcare. And I will start with a few slides. You might have seen these pictures before, but the world is changing. And this picture is from 2005. When the body of the Pope John Paul was carried across the Peter Square in the city of Vatican. 8 years later, the Pope Francis was speaking to the crowd at the same place when he has newly been elected, and this is the way it looked like then. So, in 8 years, a lot happened, and you know that, of course. Finland has been a forerunner in mobile technology. Ashley, did you see that Finnish tourist on that previous picture? We go back. You see there? It's not Nokia. Sorry, Marco. So anyway, a lot has happened, and this is in fact changing the whole way we are interacting with each other. We are sharing experiences. We are checking things with each other. We are creating information and data, and this will of course also impact the way we are dealing with healthcare. When patients today come to doctors, we hear when we meet doctors that they are getting bunches of papers or at least with iPads information about their disease, and sometimes the patients seem to know more about their disease or their symptoms than the doctor. So if we look at this change that we have seen here for the past 8 years, how has this been in healthcare? And we go back to the time when we had black and white. This was the time when the medical decisions were made by a single person. Much of the insight and the experience was in the head of this single doctor. The documentation and the whole communication regarding the information was on paper, read in books, and you had to be sometimes a bit lucky to meet the experienced doctor for your symptoms. A bit trial and error methodology, you could say. So what has then happened? How does it look today? We know it's happened a lot. We should say that we are having a very good healthcare system in general. We are treating diseases today that we couldn't dream of just 10 or 15 years ago. But even though we are having electronic medical records today, even there the Nordics have been forerunners, this is still relying very much on papers. And to be honest, the electronic health records we're having are more or less digital copies of those paper journals we had 15 years ago. So at the same time, we're creating more and more information into those digital health records, quality registries, databases, and that is creating an urgency. There is an urgency of this data, because if we are not using this data optimally, how will we then be able to have an evidence-based healthcare system, which we're all striving for? This image is kind of interesting because when we look at the amount of data in the different categories, we see that the clinical data is a small portion. The 1100 terabytes, it's a 1 with 15 zeros, is what we expect that a human being is creating over a lifetime. And that's the exogenous data that is the big portion. The socioeconomic data, the all V's of volume, variety, velocity, and veracity, all the data that we're creating about where we are, about information that we are posting ourselves, that is the area where we will see a huge growth of data. And that data has to be taken into account when we are making a good treatment for a patient, a personalized healthcare. Some more figures. We are also spending a lot of efforts in research globally. Every 30 seconds, a new paper is published, scientific paper. It's no way that a doctor will be able to keep up with all the new insights and knowledge that is being created. So the old routines on how we are treating information, data, and knowledge are not applicable anymore. Looking at the clinical trials, 170,000, and only 6% are completed on time. There we also have an issue. It takes too much time for a new drug to get into the market, 10, 15 years or more. And too few patients are enrolled in clinical trials, maybe 3 to 5% of the patients. And there are more potential there. So the problem here is that finding the right clinical trial for the right patient. And of course, if that is a manual process where you have to look in registries or these databases of these clinical trials, the clinical trials will suffer from that. This is an interesting graph, I think. It comes from one of the IBV reports that IBM is producing. IBV stands for Institute for Business Value. These reports are created for different industries, and here we're addressing healthcare. And this is actually showing a bit on the slope, going from a healthcare system that is more art than science, this black and white doctor again, to becoming a more system that is more based on science than art. And if we're looking at where we would expect us to be right now, we are probably somewhere in the middle. We are having a consensus-based healthcare system where we're having these rounds and multidisciplinary team meetings and gathering the most experienced doctors regarding the most critical cases and so on. But we still have a way to go to really claim that we're having an evidence-based care system. And we have even more to go before we're having the personalized healthcare system in place. Because the personalized healthcare system will require that we also take into account the patient information and the patient involvement better than we're doing today. This is an image I have lended from the hometown, Stockholm. It's from the Stockholm County Council. They have a plan, like you're having here in the region of Hus, about the future healthcare. And their future healthcare plan is putting the patient in the center. We heard it this morning in the panel that is the way we all think. But I think it's important also to see that the patient here is not just in the center, but it's also becoming a very central part in the whole interaction between the ecosystem around the patient. Stockholm County Council has one main goal, or I would say many goals, but one main goal is to move much of the healthcare from the acute hospitals and the specialist clinics towards closer to the patient in the primary care. I think that is something that most healthcare systems has to transform, because we know that healthcare is becoming more expensive. Our new hospitals are not able to cope with the number of more critical cases we have to handle. So the easy cases, we have to move closer to the primary care. But how can you expect that, for example, a general practitioner will be able to make an evidence-based decision, a high-quality decision, when they meet a big variety of patients every day and do not have that special insights? How can you compare a general practitioner with a specialist professor or doctor in the acute hospital that only sees that kind of diagnosis or that kind of disease every day? So we have to create something here to make this system really work. And if we put in what we then talk about, big data analytics and advanced analytics, it could look like this. We need to support the healthcare system with information about what is happening and why did it happen. This is kind of basic business intelligence. We apply it in other industries also. We need to know how a business is going, and we need to know how the healthcare system is going. We heard from Catalonia earlier this morning that is something they are doing. They are benchmarking, and benchmarking is important here because we need to know how well we are performing. It's not about pointing fingers in the healthcare system, but it's learning, it's adapting, it's changing, it's improving. And when we know what has happened and why it happened, then you can apply the predictive analytics. You can start seeing things ahead of it, they really occurring. I will give some examples on that. And give actually decision support on what action should I take based on what we know and those different modelings that we are able to do. There is a fifth dimension that I will not speak so much about now, but my colleague Amir will come to that, and that is the cognitive part. If we have a system that can understand what has happened and what the decisions have been in the past, how could you apply that so you're not doing the same mistakes again and getting this kind of learning capability into the system? But we will hear more about that in some minutes. So a few of the case studies, I have 4 that I will go through, and the first one is from Canada, the hospital's sick children. This is a situation where we're having premature kids, and you know that when it's very small, it's a very small baby, they are very sensitive to infections. And what we did here was that we were applying streaming analytics that really could look at all the different data that was streamed from these babies, looking at the heartbeat, the oxygen, all the different vital signs that you are getting from the babies. Applying patterns on what the specialist clinicians already knew, that when these different triggers are occurring, we see a risk that this patient will develop a disease or an infection. Putting those patterns and rules into place, we could actually then start predicting those infections to happen 24 hours they in fact happen. So this is a way of applying these kind of predictive analytics and avoid diseases or complications to happen. This is a live example, and it's been running for a couple of years now actually, and it's been presented in different seminars and conferences around the world. So the Hospital Sick Children Toronto. This is another interesting example. Sorry for the busy slide, but I guess you will get the presentation afterwards so you can read some of the details. It's the Seton Healthcare family. It's another US organization. They were addressing the readmissions they are having with congestive heart failure. Certain amount of their patients came back within a month, and they needed to understand why. Are there patterns here? So they gathered their specialists in the clinics and trying to see which are the predictors, which are the candidate predictors that probably could point us into directions. For example, if a patient had been in having a heart attack 6 months before, some of those kind of, you could see obvious predictors. But any of those indicators were not really showing any patterns. When you apply that into the structured information they had in their EMR, they couldn't really see any good patterns. So we got involved, and we were able to start working with the unstructured information. And I think this is a very important point here, that even though it's very important to have structured information in healthcare, we're looking for nomenclature and I would say codings and so on that should be universal. But at the same time, much of the information will be and remainly be unstructured. For example, clinical notes, information from the patient itself, or other notes. Here, for example, the living arrangements, as you see in the structured data, was not even, you couldn't even capture it in the structured information. But in the unstructured information, it was very clear. It could be that a nurse had been writing that he or she was living alone, or even there were examples here where the patients that were picked up by a taxi by the reception, that was like a small note somewhere. There you could see a pattern, and they could start wondering what does that have to do with a readmission of a congestive heart failure? Yeah, because these patients didn't have a social network around them. They got home, they had an empty fridge, they didn't have anyone who could take care of their rehabilitation, their medicine, and so forth. These patients had a higher risk for these readmissions. So these top 18 indicators that we are putting in here, some of them are the logical ones that you would expect to see there, but some of them are really new ones that were occurring during this work. So unstructured information, that's something we will need to be able to handle also in the future. Moving to my hometown again, the Disease Prevention Institute, Smittskyddsinstitutet in Stockholm, actually wrote an article 3 summers ago, that after this swine flu, actually I recognized that in a previous presentation also, even though my Finnish is limited. After that swine flu, they were seeing that we need to find another way of predicting pandemics, and also the flu when we believe it will occur. There are predictors. They are looking at Googlings. They are looking at prescriptions of medications and so forth. But it's a very manual work. So we got in contact with them, actually together with the company Tieto, which you know very well from here, of course. And we started looking at the data that is available to do those predictions. And we have this national patient index in Sweden, not very used actually, but it's there. One of the regions are, however, using it very well. So we had a very consistent database of patient information, and we could just looking at the diagnostic codes, looking at patterns on where they were living, and seeing that applying it to statistics that the Disease Prevention Institute had, we could make those kind of graphs and follow that back 10 years, seeing that this is, for example, an indicator that the annual autumn flu is coming. So that is an easy way of using old data, applying a rules engine and advanced analytics on top of it, and start making an alert system. So the system is called SWE Alert, and it's being used by the Disease Prevention Institute. I guess I am not having this full time that I'm seeing here because I think we were a bit late here, so I will speed up. The fourth example here, also from Stockholm, is from the Regional Cancer Center. They approached us last year as part of the big discussions around Watson for healthcare, which you will in a bit hear more about. They wanted to see how could Watson be applied to the Regional Cancer Center that has the role of assuring that the cancer treatment in the country is being equal, fair, and of high quality. We started looking at that, and we quite early saw that Watson in its whole was not the solution to what they were really asking for. They want to see patterns on combination of drugs, correlations with other diseases, variation on treatment plans, socioeconomics, those kind of factors. And we say we can probably do this with some components that, by the way, are used in Watson. But we started using we started with the data readiness, looking at the data that we had in the quality registries and in the patient information systems, applying something called similarity analytics, starting seeing patterns based on that, and then based on that, then using also the predictive analytics to see patterns that may occur based on a certain profile. And this was a very powerful exercise that we did. We see that just by combining different registries, information in a socioeconomic registry with clinical information, for example, immediately showed interesting and important findings and patterns. So this kind of journey is something that we are continuing, and we are also developing similar programs and projects with other clinics that are seeing that even though they might have a very advanced vision of applying analytics into their system, there are steps on the way that really can mean a lot and make a lot of a difference by starting with that. What if you could ask any question and get the answer like this to any question you ever asked, and start interacting with your computer in the same way that we are interacting with each other here? That is what is around the corner. That is what is going to change the way man and machine is interacting. And that is what Amir will talk more about. I will just end with this slide. It's going to be hopefully also with the deck that you will see. These were the IBV reports I was mentioning. You can go into the website, and they are free to download. There are some good thought leaderships there to look in. It's also a bit of the front views on what will happen in the domain of analytics. So by that, I think my time is out.